Hi, welcome to the INS recall of the surgical gastroenterology paper of last year, this year and the previous October 2024 sessions. So I'm Dr. Bharat and I'll be covering the stomach and small bowel session. The stomach and small bowel session, the number of questions, at least in the last 1 or 2 years, have been slightly on the lower side in the INISS. So let's look at the questions what we have recalled in the previous in this year from the INISS. So the first question is, which of the following is the correct descending order of involvement of GIST in the gastrointestinal tract? So from the highest incidence to the lowest incidence, the question is asking the descending order of involvement of incidence of GIST in the GIT. So we all know that stomach is the most common site of GIST. So when you take a look at these options, so obviously options C and D, C is ruled out. So stomach is the most common. So next most common is small intestine, followed by colorectum, and last is the esophagus. This is well documented in Shackelford, where they mentioned that 55% of GISTs occur in the stomach, 30% in the small bowel, 6% in the rectum and colon, and less than 1% of GIST occur in the esophagus. So the correct sequence as per the descending order of incidence is option B, that is stomach, followed by small intestine, followed by colorectum, and finally the esophagus, which is the least common. So let's see the next question. So this question has been repeatedly asked previously when AIMS was a separate exam, and now in INISS. Which of the following is a contraindication for stricturoplasty? So multiple option A, multiple short strictures within a short segment of bowel. Option B, long segment stricture of 20 centimeters. Option C, poor nutritional status. Option D, recurrence after previous resection. So here, as so basically the question is asking resection versus stricturoplasty, where we prefer resection, where we prefer stricturoplasty. So option A, short structures within a short segment, definitely we will go for stricturoplasty. Long segment stricture of 20 centimeters. This is a very long segment stricture. So usually in this scenario, we prefer a resection and anastomosis. Option C, poor nutritional status. Again, it is we prefer a stricturoplasty rather than a resection and anastomosis. Recurrence after previous resection, definitely we will uh, prefer a stricturoplasty to preserve the length of the bowel. Multiple resections in Crohn's predisposes to small bowel syndrome. So this is what Shackelford says. Stricturoplasty is generally considered the preferred approach to Crohn's, but it is inappropriate in the setting of active inflammation or infection when there is a large phlegmon, when the length or number of strictures within a given segment makes resection a better option, or when there is a concern for malignancy. So the correct answer is option B. Usually up to 10 to 15 centimeters, we can consider a stricturoplasty. More than 15 centimeters, better to go for a resection rather than a stricturoplasty. All right. So option A, C, and D, these are the scenarios we prefer stricturoplasty, and correct option here is option B. Right. Next question, just a memory-based question asked in the recent INI. What is the gauge of the outer cannula of the Veress needle? Option A, 18, B is 16 gauge, C 14 gauge, and D is 12 gauge. So here, when you look at the parts of the Veress needle, the outer gauge what we call it as the cannula, it has a 14 gauge or a 2 millimeter in diameter. So here the answer is option C, 14 gauge is the correct answer here. 14 gauge is the correct gauge size of it's the standard gauge size of the Veress needle cannula. I think regarding the previous question, someone had a doubt. Does multiple small stricture in a small segment also prefer resection? So Dr. Rajkumar has asked this. Actually, as much as possible, we try to preserve the bowel here. So when it is a small stricture within a small segment, definitely we will go for a stricturoplasty. Next question regarding physiology of small bowel. Which of the following is not absorbed in the jejunum? Option A, iron. Option B, calcium. Option C, magnesium. Option D is folic acid. So again, it's a memory-based question. Has been asked both in NEET and INI. So I'm sure many of you know this as well. Very well, we know that the iron is almost always absorbed in the duodenum. So the remaining electrolytes, that is calcium, magnesium, and also the micronutrients, these are all absorbed in the jejunum. Folic acid as well is absorbed in the jejunum, whereas of course vitamin B12 is absorbed in the ileum. So this is what Shackelford has to say. Absorption of iron from dietary sources takes place in the duodenum in the presence of bile. It also mentions the mechanism of absorption of iron in the duodenum. So bile, usually what it contains is the apotransferrin, which is a molecule that binds with the free iron in the diet, as well as with hemoglobin and myoglobin. So apotransferrin binds with either iron, hemoglobin, or myoglobin. And once this is bound, it becomes transferrin. Okay. Apotransferrin gets converted to transferrin after binding with free iron or hemoglobin or myoglobin. What this transference happens is it binds to the membrane receptors on the intestinal epithelium, and there it gets absorbed into the cell via pinocytosis. Once it is in the cell, the transferrin and iron product will pass into the circulation, and there it forms the plasma transferrin. So all this process happens in the duodenum. Okay, so bile, which contains apotransferrin, then gets converted to transferrin, which passes through into the cell and then which goes into the circulation, forming the plasma transferrin. So the answer here is A. Iron is not absorbed in the jejunum. Iron is almost completely absorbed only in the duodenum. Simple question here. Which of the following is an invasive test for detecting H. pylori in peptic ulcer disease? So here it is asking tests for H. pylori. Okay. So there are, for detection of H. pylori, there are invasive tests and there are non-invasive tests. Breath urease test, serology test, stool antigen test are all non-invasive tests. Very obviously, the endoscopy is a invasive test. So it is a very straightforward question. Answer is D, endoscopy. Okay, endoscopy is the invasive test for detecting H. pylori peptic ulcer disease. Right. So in the small bowel in embryology, when does the bowel start entering back into the abdominal cavity? So this is a question regarding the embryology of small bowel or the midgut. Okay. The options are A, 10th week, B, 14th week, C, 8th week, and D, 5th week. So we all know that because of the rapid development of the midgut, the gut outgrows the abdominal cavity and comes out of the abdominal cavity. Later it goes back in. So it is asking when it starts going back in. Which week of embryological life does the small bowel start going back into the abdominal cavity. So again, Shackelford, what does it say? So as I said, the small bowel starts lengthening, and as it lengthens, we all know that the gut rotation happens. Total of 270 degrees, initial 90, followed by, while it comes back, another 180. Total of 270 degrees. It initiates in the 5th week. Okay, 5 to 7 weeks, it comes out. Okay, 5 to 7 weeks, the small gut comes out of the abdominal cavity, and initially it rotates 90 degrees counterclockwise, and during this 90 degrees, initially the ileum will be placed in the left upper abdomen after 90 degrees rotation. Then when the fetus embryo reaches 10th week of gestation, it starts retracting back. So retraction happens between 10th and 12th week of embryological life. So this takes place for another 180 degrees, same in the counterclockwise direction. So total of 270 degrees rotation happens in a counterclockwise direction. So it starts in the 5th week to come out, and it starts again going back inside at the 10th week, and it is completed by 12th week. Okay. So all this happens in the around the SMA, that is the artery of the midgut. So the correct answer is A, 10th week. It starts entering back in the 10th week of gestation. All right. So the correct answer is A here. Next question, what is the location of pacemaker cells of the stomach? Okay. So pacemaker cells are located in a particular portion of stomach. So the options are A, fundus, B, body, C, incisura, or the D, cardia. So what does pacemaker cells of the stomach do? It initiates the gastric peristalsis. Okay, so where it's located? So this is a again picture taken from Shackelford. As you can see, it is located along the greater curvature in the body of the stomach. Okay, what does it do? It stimulates both the filling and mixing of food in the body and antrum. So predominant function of the body and fundus is receptive and accommodative relaxation, which helps in filling of the stomach. Predominant function of the antrum antropyloric region is, it is the antropyloric mill effect. That is, it helps in churning of food and mixing of food. Fundus and body is involved in filling of stomach. Antrum and pylorus is involved in mixing of food. So the answer here is B, body. All right. So that is where the pacemaker cells of the stomach are located in. Next question, the incidence of dumping syndrome is highest after which surgery? A, Roux-en-Y gastric bypass, B, pyloroplasty, C, Billrod 2 anastomosis, or D, sleeve gastrectomy. So we all know dumping syndrome is a common post-gastrectomy syndrome after gastric resection or bypass surgery. So the question is asking, amongst these surgeries, which has the most common incidence, highest incidence? So we all know that pyloroplasty is done to reduce, gastric resection, and some amount of dumping will be there. Billrod 2 also definitely dumping will be there. Sleeve gastrectomy also dumping will be there. Roux-en-Y gastric bypass, however, has the highest amount of incidence of dumping syndrome. Okay, so the incidence of dumping syndrome depends on what kind of procedure has been done, whether it's a resection of the stomach which reduces the total capacity of the stomach, or which alters the physiology of the stomach. Here in Roux-en-Y gastric bypass, both are done. Okay, so what does Shackelford say? The flow of liquid out of the stomach is determined partly by intragastric pressure and partly by the pyloric resistance. Okay, when both intragastric pressure and pyloric resistance are altered, okay, so that is where you get the maximum amount of dumping syndrome. The procedures which alter only the intragastric pressure is vagotomy, sleeve gastrectomy, or fundoplication. Procedures that alter only pyloric resistance are gastrojejunostomy or pyloroplasty. procedures that alter both the intragastric pressure as well as the outflow resistance are gastrectomies and Roux-en-Y gastric bypass. They have the highest amount of dumping, and within that Roux-en-Y gastric bypass, because it has a very small pouch, also there is a gastrojejunostomy done. This has almost 75% of incidence of dumping in patients who undergo Roux-en-Y gastric bypass. Patients who undergo only Billrod-2 also have up to 70% of dumping syndrome. And patients who undergo subtotal gastrectomy, they have around 67% of early dumping and 38% of late dumping syndrome. All right. So remember that two physiologies affect the incidence of dumping, that is the primary gastric volume as well as the outflow pressure, that is the pyloric pressure. Whatever surgery alters both to the maximum extent have the maximum amount of dumping syndrome. Here the answer is A, Roux-en-Y gastric bypass. Right. So actually, we were not able to find out, take the exact CT that was asked in INI SS, but similar CT we found. So this question was a case scenario: a 33-year-old lady who is a known case of Crohn's disease presented with chronic right-sided abdominal pain, severe weight loss, and reduced appetite. CT scan was done, and it is shown here. Which of the following is the ideal line of management for her? Options are A, step up approach and if surgery if no response. Option B, top down approach and surgery if no response. Option C, surgical resection of strictured segment. Option D is stricturoplasty. So let's take a look at the question again. Already the patient is a known case of Crohn's disease. She is a relatively young lady who's having chronic symptoms, chronic right side abdominal pain, weight loss, and reduced appetite. Severe weight loss has also been mentioned. So obviously she is malnourished. So she has undergone a CT scan. When you take a look at the CT scan, it shows a long segment stricture followed by mesenteric vascular hyperenhancement. This is called as Coombs sign. Okay, this is typical of Crohn's disease of small bowel. Long segment stricture is there. So how do we decide what management to do for this patient? Okay, so here what it looks like is definitely is proximally bowel is dilated. Okay, so it's not a high grade stricture. There is not much fecalization. There is bowel diameter looks not too high. So all these points towards a chronic presentation rather than a acute presentation requiring a emergency surgery. All right. So what does the guideline say about management of Crohn's, especially when they come with severe symptoms? So this is a severe symptoms when they develop a stricture causing a weight loss and malnourishment. So definitely these are severe symptoms. So what does the guideline say? It is better to go with a maximum biological agent initially, maximum dose of medical management right from the first. So this is called a top-down approach. Okay, so top-down approach is what is recommended when patients present with severe Crohn's disease or there is a complication of Crohn's disease. So definitely patient has a complication but does not warrant a surgery immediately. So as much as possible, we try to avoid surgery. So let's see what the Shackelford, latest edition of Shackelford say here. So a chronic stricture is more likely to lead to food avoidance, weight loss, failure to thrive, and malnourishment over time. Yes, definitely that's what this patient has. Hospital admission might be required for either disease course for medical and or surgical therapy. If there is no evidence of bowel compromise or peritonitis on examination, patients with obstructive symptoms should be initially managed with bowel rest, nasogastric decompression, and resuscitation. So following contrast studies to assess the inflammation in the area of stricture, and if there is a stenosis, aggressive medical therapy could avoid the need for operative intervention. So if there is intermittent low-grade obstructive symptoms, patient should be counseled on a low residue diet to reduce the incidence of partial bowel obstruction. All right. So that is what is recommended. Aggressive medical therapy for patients who have complications but not warranting immediate surgery. So here answer is B, a top-down approach followed by surgery if there is no response to medical management. So directly we go with high dose of biological agents in this patient. So answer is B. So next question, all of the following abnormalities are seen in refeeding syndrome except options are A, hypomagnesemia, option B, hypophosphatemia, option C, hyperkalemia, option D, thiamine deficiency. So simple, I think this is a straightforward question. So answer is C, hyperkalemia. We all know there are multiple electrolyte abnormalities in refeeding syndrome due to sudden utilization of all the electrolytes. There will be severe reduction of magnesium, phosphate as well as potassium, and severe thiamine deficiency due to rapid utilization of thiamine. So answer here is C. Similar question was asked regarding refeeding. I think refeeding multiple times has been stressed upon in the previous exam as well. So another question was, while giving TPN, what steps are followed to prevent refeeding syndrome? So options are A, slow escalation of feeds. Option B, high calorie, low protein feeds. Option C, avoid lipids in the total parental nutrition. Option D, avoid addition of vitamins in total parental nutrition. So let's see what are the steps to avoid refeeding syndrome when you are planning to give a total parental nutrition. All right. So before you start total parental nutrition, you have to assess the risk of the patients who are having the highest risk to have refeeding syndrome. These are patients who have severe malnourishment, that is BMI usually less than 18.5, significant weight loss, or little to no nutritional intake for an prolonged period of time. These have the highest risk for refeeding syndrome, and it is important that before you start TPN, you identify these patients. Also, we have to obtain a baseline blood levels of electrolytes, which you usually go down during refeeding syndrome, like phosphorus, potassium, and magnesium. And definitely, we have to supplement thiamine. We have to administer thiamine before starting TPN or any dextrose containing IV fluid to help prevent refeeding syndrome, right? During TPN, what do you have to do? You have to start with a low calorie intake, because as soon as you give more calories, there will be sudden intake of sudden utilization of all electrolytes as well as vitamins, and there will be rapid fall in serum levels of these electrolytes and thiamine. So we have to give a low calorie intake. So we have to aim for less carbohydrates and as slightly more protein intake for during the initiation of TPN. And so that is what we have to reduce carbohydrates and aggressively monitor the electrolytes, same electrolytes, that is phosphorus, potassium, and magnesium. Simultaneously, we have to supplement electrolytes, multiple vitamins, and especially thiamine and micronutrients. Okay. So what happens in refeeding syndrome? Patients have chronic catabolism and or malnutrition. So inherently, they will have a low insulin levels in their body with high glucagon levels. So this causes in their body the mechanism of protein catabolism, glycogenolysis will be taking place. So when we start feeding with excess carbohydrates with a high calorie diet, there will be increase in insulin secretion, leading to increased protein synthesis, increased use of thiamine, rapid shift of potassium, magnesium, and phosphate into the cells, causing hypophosphatemia, hypomagnesemia, hypokalemia, and thiamine deficiencies. Okay. So that is the pathophysiology of refeeding syndrome. Most common abnormality seen in refeeding syndrome is hypophosphatemia. The first one is the most common. So the answers here are, the options are option C, hyperkalemia is not seen. It is the hypokalemia which is seen. And in the next question, how to prevent refeeding syndrome. We we have to do a slow escalation of feeds. That is, answer is option A. So we should do a low calorie diet initially, and definitely we have to give lipids in the TPN, and absolutely we have to give vitamins in the along with TPN. So these are the two things. So that's it regarding stomach and small bowel recalls. The other systems will be covered subsequently by other faculties. So please log into that as well and watch it. Thanks for watching this session. Have a good day. Thank you.